Hello, everybody. It's Ryan here. Hope you and your family are well. I certainly hope that I deliver on today's presentation. We're going to be talking about cirrhosis. Very topical, very relevant. God bless you. Thanks for joining me. This is an overview of the talk today. We're going to be breaking down a clinical case and then taking a closer look at cirrhosis in terms of our cardinal headings. And you'll notice that the theme of most videos on my channel has this layout. These are the cardinal headings: etiology and classification, some pathophysiology, patient presentation in terms of signs and symptoms, differential diagnosis, diagnostic evaluation, treatment and management, and then prognosis and complications. Then we're going to end off with scripture. Thank you so much for joining me. God bless you. Don't forget to like, share, and subscribe. Okay, here we go. 63-year-old man with cirrhosis and portal hypertension due to hemochromatosis presents with an altered mental status. He has chronic ascites controlled with diet and spironolactone, which is an aldosterone receptor antagonist. He has a history of one esophageal bleed, but none since starting prophylaxis in the way of propranolol. His family reports that over the last 2 days he has become more confused, but he has had no melena nor hematemesis. He is afebrile with normal vital signs and a physical exam that is notable for ascites, asterixis, and being oriented only to person. His labs are notable for a hemoglobin of 10.1 gram per deciliter with a baseline of 9.5, creatinine of 134 micromole per liter, so there's some degree of renal impairment, with a urea of 12.2 millimole per liter. Paracentesis is performed that yields clear fluid with 800 white blood cells per microliter, 40% of which are neutrophils. Which of the following is the most indicated therapy? Is it A, ampicillin, ceftriaxone, vancomycin? Is it B, cefotaxime, which is I think it's a third generation cephalosporin? Is it C, upper endoscopy with banding, D, hemodialysis, or E, lactulose? Nice to ask. Okay, everybody, what really is cirrhosis? Cirrhosis is the end result of prolonged, indolent, grumbling hepatocellular injury, resulting in two things: fibrosis and nodular regeneration. Fibrosis and nodular regeneration of the liver. Now, remember that these structural changes may impair liver function as manifested by jaundice and coagulopathy. Right? We'll talk about the different functions of the liver, especially the synthetic function of the liver. May also manifest with portal hypertension and hepatocellular carcinoma as a complication. Complications of cirrhosis are numerous, including liver failure, encephalopathy, massive GI bleeding on the back of esophageal varices, renal failure, something we call hepatorenal syndrome. There's also a whole host of hepatopulmonary syndromes, ascites, spontaneous bacterial peritonitis, hepatocellular carcinoma, among others, right? So this is just to illustrate the different kind of histological stages one progresses through in terms of progression to cirrhosis. So here we have a normal liver, right? Nice hepatocytes we can see there. And then here we have the stage of steatosis, which is fatty filtration. Now, steatosis can be alcoholic steatosis, can be non-alcoholic steatosis, and that then progresses to steatohepatitis, which is a mix of hepatitis with fatty infiltration, all right? We have portal inflammation, right? And that then eventually progresses through to cirrhosis. And we say the hallmarks, histopathologically speaking, are areas of fibrosis, right? So laying down collagen in the hepatocytes or between the hepatocytes. And we have these regenerative cirrhotic nodules. And eventually, a complication of long-standing cirrhosis can be hepatocellular carcinoma. Alrighty. Right. So let's look at etiology. Most cases of cirrhosis are due to chronic alcohol abuse, viral hepatitis, non-alcoholic steatohepatitis on the back of diabetes, very especially, and hemochromatosis. So those probably account for majority of the cases of cirrhosis that we see. Other etiologies include autoimmune hepatitis, primary biliary cirrhosis, which is now retermed primary biliary cholangitis, primary sclerosing cholangitis, worsens disease, alpha-1 antitrypsin deficiency. This is taken from Harrison's, which shows us pictorially the different causes of cirrhosis in another way. So we can see alcohol by and large the most common, followed by chronic viral hepatitis. Hepatitis B and C are the flavors that give you chronic viral hepatitis. Autoimmune hepatitis, all right, non-alcoholic steatohepatitis. Then there's biliary cirrhosis in the way of primary biliary cholangitis, primary sclerosing cholangitis, autoimmune cholangiopathy, cardiac cirrhosis from long-standing cardiac failure, especially right-sided, inherited metabolic liver disease in the way of hemochromatosis, which speaks to iron overload, Wilson's disease with its copper overload, alpha-1 antitrypsin deficiency, which keeps company with lower lobe predominant emphysema, okay, cystic fibrosis, and then, of course, cryptogenic when we don't really know what's going on. But the pathophysiology of cirrhosis, what is it? Nice to ask. The clinical features and complications of cirrhosis result from, firstly, hepatic cell dysfunction. And remember that the synthetic function of the liver is reflected by the INR, because INR reflects your synthesis of clotting factors and your albumin. So hepatic cell dysfunction will manifest with diminished synthetic function in the way of decreased production of clotting factors, which will raise your INR and, of course, decrease your albumin. All right. The next thing is portal hypertension with polysystemic shunting, and this will manifest with esophageal varices, splenomegaly, Kappa-Medusae. All right. The third thing is decreased metabolism of toxic substances, especially ammonia, and this is going to result in hyperammonemia, and that is what causes hepatic encephalopathy. All right. And the fourth thing is destruction of bile flow, resulting in cholestasis and jaundice with an elevated alkaline phosphatase, okay, which is one of your cholestatic or your ductal enzymes. How do patients with cirrhosis present? So the presentation is highly variable, ranging from an insidious onset of very vague symptoms like fatigue, weakness, malaise, some abdominal discomfort, weight loss, anorexia, nausea. And so it ranges from that through to decompensated cirrhosis with coagulopathy, renal failure, hepatic encephalopathy, gastrointestinal bleeding from bleeding esophageal varices, or even sepsis. Because remember, the Kupffer cells in the liver play a very important immunological function, and their function is lost in the setting of cirrhosis. Signs of liver failure, right, may also complicate cirrhosis. So be on the lookout for jaundice, spider angiomata, palmar erythema, gynecomastia, testicular atrophy, bruising, and coagulopathy, right? Signs of portal hypertension we know include ascites, esophageal varices on the back of which can cause GI bleeding, Kappa-Medusae, splenomegaly, and hemorrhoids, right? I'm sure all of us are familiar with these things. Signs of hepatic encephalopathy include lethargy, confusion, acidixis, which is flapping of the hands when flexed at the wrist, and of course hyperreflexia. So this is taken from Macleod. It shows us a beautiful summary of the different findings you want to expect in someone who has chronic liver disease or cirrhosis, right? So in the hands, you look out for leukonoikia, which is white nails, look out for palmar erythema, which reflects the increase in your estrogen to testosterone ratio, and of course, clubbing, all right? This is a beautiful picture of leukonoikia, which reflects hypoalbuminemia. This is palmar erythema demonstrated here. In the chest, you want to look out for gynecomastia in men and breast atrophy in women, as well as look at the armpits and the facial hair, because there's loss of male pattern body hair. There's axillary alopecia, which keeps company with testicular atrophy, right? All reflecting the increased estrogen to testo ratio. Eyes, remember you have jaundice, and the upper half of the body above the umbilicus is where you see spider nevi. In the abdomen, watch out for splenomegaly, which is probably caused by portal hypertension, hepatomegaly, but classically in cirrhosis, the liver is small, dilated collateral vessels around the umbilicus called Kappa-Medusae, testicular atrophy in the genitals, right? In the legs, we have edema and hair loss, and generally you may see skin pigmentation with loss of body hair. So, guys, this is a beautiful picture of spider angiomata. We'll see another one coming up. In a jaundiced patient, finding spider nevi, palmar erythema, and ascites all suggest strongly this patient has chronic liver disease rather than obstructive jaundice, right? The signs of liver failure, fetor hepaticus, flapping tremor of acidixis, mental status changes. Late neurological features include spasticity and extension of the arms and legs, extensor plantar responses, alrighty. This is a beautiful picture of a spider angiomata, and this is, of course, taken from Harrison's, and it shows that with central compression, the arteriole fills from the center and then spreads out peripherally. Looks like a spider. This is palmar erythema, and here we can see that the erythema is peripheral over the palm with an area of kind of central pala. Okay, this is the grading of hepatic encephalopathy called the West Haven grading from 0 to 4. So in stage 0, there's actually no change in personality or behavior and no acidixis. By stage 1, there is concentration becomes impaired, attention span is diminished, and this classically presents with sleep disturbance, slurred speech, and acidixis is present. In stage 2, there's lethargy, drowsiness, apathy, disorientation, inappropriate behavior, slurred speech. Stage 3 is where the patient becomes stuporose and drowsy with bizarre behavior. Acidixis is usually absent at this point. And stage 4 is comatose with no response to vocal commands, minimal or absent response to painful stimuli. Okay, everybody, when we're talking about portal hypertension, remember cirrhosis is only one cause of portal hypertension. It's the intrahepatic sinusoidal cause. But the way we break down portal hypertension is in terms of, pre-hepatic, intrahepatic, which is further stratified into pre-sinusoidal, intrasinusoidal, and post-sinusoidal, and then we get post-hepatic, right? So in terms of your pre-hepatic etiology, before, talking about the blood supply before it comes to the liver, they would talk about portal vein thrombus and splenic vein thrombus, a common complication of chronic pancreatitis. Intrahepatic causes pre-sinusoidal, we can look at idiopathic portal hypertension, primary biliary cholangitis, sarcoidosis, but very common is schistosomiasis, right? Intrasinusoidal causes common cirrhosis. Alcoholic cirrhosis, alcoholic hepatitis, cryptogenic cirrhosis, post-necrotic cirrhosis. Post-sinusoidal, intrahepatic has to do with sinusoidal obstruction syndrome. Then we're looking at the post-hepatic flavor of portal hypertension. We speak to Budd-Chiari syndrome, which is actually hepatic vein thrombosis. And then, of course, something coming from the heart, chronic constrictive pericarditis. What about IVC obstruction? What about right-sided heart failure? Severe tricuspid regurgitation, which gives you your beautiful pulsatile liver. Okay, so how does ascites develop in cirrhosis? What's the pathophysiology behind this? So cirrhosis causes portal hypertension, right? Portal hypertension then drives splanchnic vasodilatation. Alrighty. And the splanchnic vasodilatation has two effects. We have increased splanchnic pressure, and then we have arterial underfilling. Increased splanchnic pressure, together with the formation of lymph, causes the formation or drives the formation of ascites. Arterial underfilling on the back of splanchnic vasodilatation causes activation of vasoconstrictors and anti-natriuretic factors, including the RAS system, renin-angiotensin-aldosterone, and the sympathetic nervous system, which causes you to retain sodium. That causes plasma volume expansion and further contributes to the ascites. So the ascites is actually due to increased splanchnic pressure with lymph formation and arterial underfilling, causing your RAS and your sympathetic nervous system to kick in, which causes sodium retention, plasma volume expansion, and the formation of ascites. Right. Differential diagnosis for cirrhosis, we could be dealing with primary biliary cirrhosis, or what we now term primary biliary cholangitis. It could be secondary biliary cirrhosis. It could be non-cirrhotic hepatic fibrosis, which is what we call cardiac cirrhosis in most instances due to congestive heart failure chronically or constrictive pericarditis. It could be Budd-Chiari syndrome, and that's another term for that is hepatic vein thrombosis. That's the same thing. Congenital hepatic fibrosis, partial nodular fibrosis, and portal vein thrombus we said on the back of pancreatitis, right? How do you evaluate someone diagnostically who you think has cirrhosis or has clinical features to suggest cirrhosis? So very important, the basic tenets in medicine is history and physical exam. History and physical exam. Investigations simply serves to confirm or refute the differential you developed clinically. Okay, so your history is a key factor in diagnosis with emphasis on alcohol use, exposure to drugs and toxins, viral infections, especially hepatitis, blood transfusions, sexual history, family history. Examination should pay attention to what we've just discussed in terms of the clinical stigmata of cirrhosis. So skin abnormalities like spina angiomata, jaundice, caput axillary alopecia, which speaks to the cirrhosis, right? Abdomen, you may have ascites, hepatosplenomegaly, watch out. Breast or testicular exam, looking for gynecomastia, small testes, with testicular atrophy in males, right? Neurological exam and nutritional status. Initial labs you want to do. To check for hepatocellular necrosis, you do your liver function panel, look at your transaminases, your ALT and your AST, alanine aminotransferase, and aspartate aminotransferase, right, which is your transaminases. Then look at the cholestatic enzymes, your alkaline phosphatase, your total bilirubin, and your gamma-glutamyl transferase, which speaks to the ductal portion of the cholestatic enzymes. Hepatic synthetic function, we said before, is manifested by the albumin and diminished synthesis of clotting factors, which will raise your international normalized ratio or your prothrombin time. And then you look for diagnostic tests for underlying liver disease. And then we have hepatitis serologies, especially hepatitis A to E, some viruses as well, like cytomegalovirus and Epstein-Barr. Iron studies, very important, especially the setting of hemochromatosis. Genetic testing for hemochromatosis, right, which is the HFE gene. Ceruloplasmin for Wilson's disease, right, and alpha-1 antitrypsin levels. Then you want to do imaging, right? So we can go abdominal ultrasound and CT scan, which provide evidence for abnormal liver architecture number 1, ductal dilation number 2, hepatocellular carcinoma number 3, and any other abdominal pathology. But the gold standard for diagnosis in terms of cirrhosis is liver biopsy. However, biopsy may not be necessary if the clinical lab and radiological evidence point to a diagnosis of cirrhosis, right? Biopsy may also shed light on the cause of cirrhosis, like whether this is Wilson's disease or alpha-1 antitrypsin, hemochromatosis, or non-alcoholic steatohepatitis. But if there's a clear history of alcohol use, I mean, it's purely academic to do the liver biopsy in that instance. Upper GI endoscopy in all patients to assess for esophageal varices, okay? How do we manage somebody who has cirrhosis? So the goal of treatment is firstly to remove or alleviate the underlying etiology. Then we want to prevent further liver damage, number 2. Number 3, prevent complications, which we mentioned. Number 4, assess the appropriateness for liver transplantation. So in general, guys, outpatient care with close follow-up is generally adequate, except for those who develop complications. For instance, those who have variceal bleeding, those with encephalopathy, those who have spontaneous bacterial peritonitis, those who have hepatorenal or hepatopulmonary syndromes. So variceal bleeding requires endoscopy first up to visualize and band those varices. Then you require octreotide, which serves to reduce your portal hypertension, right? Because octreotide and somatostatin analogs cause splanchnic vasoconstriction, isn't it? And then, of course, antibiotics to prevent peritonitis and beta blockers as prophylaxis. Okay, so this here we're addressing how to manage recurrent variceal hemorrhage as per Harrison's. Let's get my pen in there. So if you got recurrent acute bleeding, the way to go is endoscopy with pharmacological therapy, right? Maybe you want to give prophylaxis with your propranolol. Then you want to control the bleeding, right? If you got compensated cirrhosis, which is Child-Pugh score A, you may want to consider transjugular intrahepatic portosystemic shunt and consider liver transplantation evaluation. But if you've got decompensated cirrhosis and a Child-Pugh score of between B or C, then you want to evaluate for transplant, endoscopic therapy of beta blockade, consider TIPS and liver transplant, right? That's the way to go. In terms of hepatic encephalopathy, this is treated by simply avoiding your triggers. And triggers for hepatic encephalopathy are things like infection, dehydration, constipation, excess protein intake, narcotics, and benzodiazepines. You want to give the patient lactulose to decrease the amount of ammonia-forming bowel bacteria, and that serves to decrease your ammonia levels, because ammonia or hyperammonemia is what drives the encephalopathy, right? Antibiotics serve the same purpose. Surgical shunting may be necessary for advanced cases in the way of TIPS and so forth. In terms of spontaneous bacterial peritonitis, this is simply an infection of acidic fluid that we address with IV antibiotics. Prophylactic oral antibiotic therapy may reduce the risk of future events. Right? We'll talk a little bit about that shortly. How do we address refractory ascites in the setting of cirrhosis? So ideally, you want to make sure that your albumin level, is increased, right, at least above 20. Right? To this end, you want to use Albusol or some kind of plasma products that have albumin in it. Then you want to do large volume paracentesis, right? Dietary sodium restriction with diuretics, right? Consider your furosemide, consider your aldosterone receptor antagonist, right? If ascites reaccumulates, consider transjugular intrahepatic portosystemic shunting. You can continue your large volume paracentesis with albumin, consider liver transplant, alrighty? Hepatorenal syndrome is a dreaded complication or consequence of ongoing cirrhosis. Really, the only definitive treatment for that is liver transplant. We also have a variety of hepatopulmonary syndromes as well, where the presentation will be that of orthodoxia and platypnea, so breathlessness when you are sitting up, and orthodoxia is diminished oxygen saturation when you're sitting up. This is because of the formation of AV malformations in the lung parenchyma. Okay, also very important to stress strict dietary adherence. So avoid alcohol consumption, number 1. Number 2, consume less than 2 grams per day of sodium to minimize ascites. You can actually refer the patient to a dietitian with practical advice on how to do this. Thirdly, minimal protein to avoid encephalopathy, because protein gives rise to ammonia when it's digested and absorbed, and that precipitates encephalopathy. Fluid restriction to 1 to 1.5 liters per day. Vaccinate against hepatitis A and B. Okay, what's the prognosis, guys, with cirrhosis? The prognosis is highly variable, does not necessarily correlate with the degree of the histology. Now, the Child-Turcotte-Pugh classification is used to assess the hepatic functional reserve. A score of greater than 10 suggests 50% mortality risk within 1 year. So this is the Child-Turcotte-Pugh score, right? It assesses your hepatic functional reserve. There's a couple of elements here. We speak to the albumin, the ascites, the bilirubin, the encephalopathy, and the INR. All right, so let's just talk about this for a bit. So there's a scoring system here, right? So if your composite score is between 5 to 6, that's class A, and means that you have well-compensated disease, which correlates with the 1-year survival percentage of 100% and 85% 2-year survival. Composite score of 79 puts you into class B, which means that you have significant functional compromise with a 1-year survival percentage of 80%. And a composite score of 10 to 15 puts you in class C, right, which speaks to decompensated cirrhosis, and you have a 45% 1-year survival, 35% 2-year survival, right? So the elements we looked at was your albumin, basically above 35 or between 28 and 35, below 28, class 1, 2, 3. Ascites being absent, slight, or moderate, class 1, 2, 3. Bilirubin being either below 34.2, between 34.2 and 51.3, over 51.3 being the most severe, and encephalopathy being grade 1, none, grade 2. Grade 1 and 2 scores you 2, and grade 3 and 4 scores you 3, and your INR being below 1.7, between 1.7 and 2.3, and above 2.3. Alrighty. This is another way to represent the complications of cirrhosis as per Harrison. So portal hypertension, and the complications of portal hypertension is gastroesophageal varices, which can bleed, causing GI bleeds. Portal hypertensive gastropathy, finding on upper scope, splenomegaly, hypersplenism, right? Ascites with spontaneous bacterial peritonitis. Then hepatorenal syndrome type 1 and 2, hepatic encephalopathy, hepatopulmonary syndromes, portal pulmonary hypertension, malnutrition. There are other things like coagulopathy, which reflects the diminished synthetic function of the liver. And then we have factor deficiency, which raises your INR, fibrinolysis, and thrombocytopenia. Bone disease, right? Because you can't produce bile, and bile is responsible for emulsification of fat. And vitamin K, or rather vitamin D, contributes to calcium absorption and plays a role in bone homeostasis. That is all thrown off. So as a result, you have osteopenia, osteoporosis, osteomalacia, hematological abnormalities, and then we have anemia, right, which can come from many sources: hemolysis, thrombocytopenia, and neutropenia. There's the APRI score, which is the AST to platelet ratio, right? And this essentially is a score which helps us to predict the risk to cirrhosis. And how we compute this is by looking at your AST, your aspartate aminotransferase, divided by the upper limit of normal for the AST, divided by your platelet count times 100. If your score is greater than 1, that has a sensitivity of 76% and specificity of 72% for predicting cirrhosis. If your score is 0.7 or greater, the sensitivity is somewhat greater, right? And specificity still 72% for predicting significant hepatic fibrosis, right? There's other things we can do, like the fibroscan as well, which looks at the actual ultrasonographic features, which predicts hepatic fibrosis. But the APRI score is one way to do it. All right, so guys, coming back to our clinical case here. This in summary, we had an elderly male with cirrhosis and portal hypertension on the back of hemochromatosis, comes in with hepatic encephalopathy. He has chronic ascites, which he controls with diet and aldactone. He has history of 1 prior esophageal bleed, but he hasn't had that since starting beta blocker prophylaxis. Over the last 2 days, he's become more confused, but no melena or hematemesis. He is afebrile with normal physical exam, well, essentially normal, except for ascites asterixis being orientated only to persons, so quite abnormal then. Labs show an anemia, it shows some renal impairment, and shows a high urea. Right, paracentesis yields clear fluid with 800 white blood cells, 40% neutrophilic pleocytosis. Which of the following is most indicated? Careful, taxi. Let's talk about this spontaneous bacterial peritonitis. Now, I didn't focus on this during the meat of the talk because I wanted to save it for this question. Spontaneous bacterial peritonitis is a common and severe bleeding complication of ascites, characterized by spontaneous infection of acidic fluid without an intra-abdominal source. Now, in patients with cirrhosis and ascites, severe enough hospitalization in this demographic, spontaneous bacterial peritonitis can occur in up to 30% of persons that can have a 25% in-hospital mortality. The most common organisms or culprits implicated here are E. coli and other gut bacteria. However, other gram-positives like Cervidae, Staph aureus, and Pterococcus can also be found. Diagnosis is made if you take an acidic fluid sample, do a cell count on that, and the absolute neutrophils are above 250 per microliter. Treatment is with a second-generation cephalosporin. Okay, my friends, I hope that you will just allow me to encourage you a bit. Today we're talking about the dangers of unthankfulness. The dangers of unthankfulness as per the Bible. 2 Timothy chapter 3 verse 1 to 2 tells us, mark this, there will be terrible times in the last days. People will be, and there's a whole lot of adjectives that comes after this: lovers of themselves, lovers of money, boastful, proud, abusive, disobedient to their parents, ungrateful. right? People will be ungrateful. And we see that increasing in prevalence nowadays. Romans chapter 1 verse 21 says, "For although they knew God, they neither glorified him as God nor gave thanks to him." Right, very important. 1 Thessalonians 5:18, "Give thanks in all circumstances, for this is God's will for you in Christ." You know, there's a popular saying, if you can think, then you can thank. We should be grateful for everything we have. We should be thankful to God for everything, for we can do nothing on our own accord. Right? I hope that we will develop an attitude of gratitude. All right. Here are my references. I hope that you enjoyed this video. You can find me on Facebook. Right? My page is entitled Internal Medicine Algorithms and Mnemonics. You can also find me on TikTok and on Instagram. If you enjoyed this content, please don't forget to smash that subscribe button, like, and share it. God bless you. Thanks for joining me. We're going to be talking about type 1 diabetes mellitus, a very sweet topic, coming soon. God bless you. Take care.